Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
How do we build a concussion care model that serves everyone, not just elite athletes? In this episode of the Concussion Corner Podcast, I continue the conversation with Dr. Steve Broglio, Associate Dean for Graduate Affairs in the School of Kinesiology, Director of the Michigan Concussion Center, and Professor of Kinesiology, Neurology, and PM&R at the University of Michigan. He is also currently serving as the president of the Concussion and Sport Group. We explore persistent post-concussive symptoms, health disparities in civilian and military populations, and the growing need for inclusive, data-informed approaches that meet the needs of neurodiverse, para-sport, and tactical athletes. If you care about equity in concussion care, then this episode is for you. My name is Dr. Jessica Schwartz. I'm a physical therapist, brain injury survivor, and founder of Concussion Corner. We're so happy that you're here. Let's dive in. Dr. Broglio, welcome back to the Concussion Corner Podcast.
Thanks, Jess. Good to be here.
We highlighted some of your early career and kind of the trajectory of where you've been, all the way from young Steve Broglio all the way to Dean and President of Concussion and Sport Group, as well as key researcher in the CARE Consortium. I'd like to focus a little bit more on special populations and what we're looking at in terms of the concussion space. Everyone talks about sport and concussion, and I know that you're doing really, really great work at the University of Michigan Concussion Center. So how are you serving your community? You know, our mantra here is teach one, serve many. And I love people just really serving their communities at the highest level. So how are you changing your space in Michigan?
Sure. So, great question. And I think of utmost importance in the current context. I'll be fully transparent here. When we started the Michigan Concussion Center in 2018, we were definitely very sports centric, and mostly because that was where our expertise was at the time. But what we really quickly realized, which I think I didn't fully appreciate at the time, is we took our initial membership of, I think there were 12 or 13 of us that kind of founded the center, and we're now up to about 175 members across 25 different campus units here at Michigan. So that's just on the Michigan campus. And what we found was we now have faculty that work in the intimate partner violence space. We have faculty that work sort of what we would term kind of in the civilian space. So that's just, the regular slips, trips, and falls, car accidents, those types of things. And then, my work through the Department of Defense, we're doing a lot with military personnel. And we have a new faculty member that's going to join us in March of next year who focuses on veterans. So we're really trying to expand kind of the different communities that we work with, and go beyond sort of that sport model. I want to give full credit to Jeff Barth. And for those who don't know, Jeff was really the inventor of sport concussion research at the University of Virginia. Sadly passed away earlier this year. But really, he's the guy that got it started for everybody. And it serves as a great model. Like he was right when he did it. Is you have a group of people that you can get pre-injury data on with a known injury rate, and then you can follow them afterwards. And you get we've done a lot of great things, and a lot of that information translates really nicely over into sort of the civilian, the military, the youth space. But it's not really until you do work with those groups that you have a true understanding of it. And that's what we're trying to do.
Awesome. Where is the persistent post-concussive symptom conversation happening in the clinical side at University of Michigan? Brian Hainline talks about, and he emphasized depression, anxiety being poorly understood neuroanatomically, chronic pain and fear avoidance patterns, amplifying recovery barriers. And at the end of the day, we want to avoid reductionism, take a humanistic, patient-centered approach. And really, calm is contagious. And I think we all learned that from Dr. Hainline. Yeah. I saw him speak at a 2016 NYU lecture. And I have to tell you that the slides didn't show up, and he was like, oh, not a problem. And he just took it away. So calm really is contagious. And that was one of my biggest lessons of really just admiring the man. But where are we kind of in the persistent post-concussive symptom conversation in terms of not only the research, but how you're implementing at University of Michigan?
Yeah, so I think, I'm trying to remember exactly when, it's maybe 3 or 4 years ago, Ann Herring and Donna Broschek, Jamie Pardini, they kind of sort of rephrased kind of the way we're thinking about persistent symptoms, or PCS, and called it persisting symptoms. And they've got some really nice background work kind of on kind of the language and what the language means. But I hope I get this right, that the use of the word persisting rather than persistent implies that there's going to be an end to this, that it is resolvable. And I think they're spot on. And they sort of demarcate kind of, it's at that kind of 4 to 6 week point that sort of it becomes persisting symptoms. The biological injury has probably healed, and we're really talking about maybe some psychology or some other things that are going on. Brian knows this literature better than I do, so I trust it. He's correct that we don't really understand the neurobiology of depression and anxiety so much. But I think there's a lot of things that people can do, clinicians can do to help manage it. And whether that is exercise or medication or CBT or the combination of those three, there's a lot that we can do to help people manage depression, anxiety, other mental health issues. Here at Michigan Concussion Center, our clinicians are, they're some of the best in the world. Our neurosport clinic, which focuses primarily on sport-related injuries, they have told me, I think, about a quarter or so, maybe 20% of their practice is, they would say long-term effects, but I think it's anything at the 4 to 6 week forward and out that they focus on. Catherine Siegley, who runs sort of like our civilian, what we would term our civilian clinic, her work is almost exclusively in the long-term space. And then obviously some of the DoD work we do, it's a little bit mixed. We definitely help with acute care. This faculty member we're bringing in March, she's dealing with veterans, so that's kind of more on the long-term space. So we're sort of tackling it from many different angles. I think the bottom line that what we're seeing is that early intervention can prevent a lot. And so individuals that maybe they have an accident of some sort, whether it's car crash or slip on the ice or something similar, go to the emergency room and then just get discharged and there's no real follow-up. A lot of those are going to end up with some challenges. And the NASM report from, I think it was 2 years ago, I think it's something like 80% of individuals, that's exactly what happens, is they go to an ED and then they get discharged and there's no follow-up. So I think what we're seeing or what we're really trying to encourage is referral to a specialty clinic and some early intervention to try to mitigate some of those things.
And you had mentioned some, law enforcement and tactical conversations as well. And I think it's fantastic that you guys are actually, leaning into research with special populations and not just looking at that, again, that FIFA elite soccer player that's, on the pitch. So I'm thinking about like law enforcement officers were discussed over at the CISG meeting in Milwaukee in spring of 2025. Neurodiverse populations were brought up by Catherine McGill, which was just a standing ovation from me to just see that even broached in conversation because we know so many folks are being diagnosed. So with neurodiverse, the big thing here in New York City, everyone's getting diagnosed with is like ADHD, is the autism and ADHD. So as that is kind of getting diagnosed. And then just thinking about the parasport athletes with Rachel Smetana's work that was presented in Milwaukee, and then also with Oz, out in the UK doing tremendous work. Where are we evolving in recommendations and research and just opening the door for research for these special population groups?
Yeah, I think this is sort of the evolution of kind of where we've been. And we talked in episode 1 about how we would, do these studies of 25 people and we would just apply it to everybody, right? And those 25 people were probably football players. And I think we have recognized that, all these subpopulations have their own needs and they need their own attention and research. So I think the addition of what we would call the tactical athlete, and that can be military, it can be police, fire is another area that we think about, urgent, sport, all these groups have their own challenges. Alyssa Tinney here at the University of Michigan, she's the head of sports medicine for our parasport athletes. And is deeply entrenched in some of the concussion work. And she's part of a team that is actually developing a SCAT wheelchair module. And so you think about a wheelchair athlete, wheelchair basketball, wheelchair rugby, some of the other sports that they play. How do you do a balance test in a wheelchair athlete? They can't stand, right? So I was this is sort of serendipitous, but I had a master's student at the University of Illinois when I was there that actually developed what she called the WESS, which was the wheelchair error scoring system. Conveniently, her last name was Wessels, so it actually worked out very well for her. So that is being adopted in part into this SCAT wheelchair version. And so that's undergoing a review right now, planned to come out or be submitted for publication. But those are the sorts of things that we're sort of, more and more people are engaging in physical activity from these different populations, and we're recognizing that what they do in their daily lives is physical activity, thinking of the tactical athlete. And so we need to think about kind of what are the challenges that they have that we need to address that just don't, the FIFA athlete, it just doesn't apply to them. And so I'm part of a group, this was a very interesting experience to me, where it's an internal group in the DoD where they're trying to think about kind of doing, they're calling it a readiness screen. For military personnel. And one of the challenges is, how do you do a concussion evaluation in an austere environment? And what I mean by that is, you're out on patrol with 4, 5, 6 soldiers, somebody gets hit, how do you do a concussion evaluation? Now, if you're in the middle of a firefight, whether you can balance or not is not what you're really concerned about, right? Like it is like, I need to be able to point the gun in the right direction. And nobody's coming in to like medevac you out for a concussion. You're going to have to hike out. So how can we do like a 30-second, 1-minute screen on these individuals to make sure that it's not life-threatening, in which case they do need, and they can keep going and sort of, keep doing the job that they need to do. That's a very different question than the football athlete where you can just pull him off the field and then substitute somebody back in 30 seconds. So every job, every subgroup sort of has unique challenges that we need to think about, and we just can't put one umbrella.
Fantastic. And I remember even just John Letty's work with Matuzek et al. With a 45-minute concussion toolbox from like 2015. And then we're now looking at the visuovestibular exam from Dr. Tina Master. And then we also have the Buffalo concussion physical exam, which is again 5 to 7 minutes. And I never even thought about having to do that in theater as well. So thank you for sharing that information. And even with some of Dr. Letty's work, who's a part of our faculty here at the Academy side of things, at the end of the day, he introduced us to the March test, which is fantastic because so many of our clinicians that come through don't have a bike. Well, specifically not a bike that John has, which is like a $10,000 like bike, which I'm jealous of as a cyclist, but here we are. And then, or a treadmill even, just from a space standpoint. So just to be able to like Suzanne Summers, like bump out a step in the clinic or in someone's home is fantastic from a March test. So just making things accessible is just really fantastic to see and to see where the research is going. And I didn't know the full connection there with the West, but I'm a huge fan of West. And I would say about 95% of our students that have come through in 6 countries and 39 states across 8 professions have not heard of the West until we introduce it to them. So I'm so grateful to be able to share that information and that research that's been put out by some of your people. So it's fantastic to see.
Yeah.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show.
I mean, I think as a researcher, particularly here at University of Michigan, I have access to a lot of neat tools, and it's a lot of fun, but you're spot on. Like, do I have a $10,000 bike downstairs that I can go put someone on? Sure. But I, as an athletic trainer, also know that the average athletic trainer in a high school or maybe in a clinic doesn't have access to that. So I'm always thinking about, yeah, I could do that here, but can they do that there? And if they can't do that there, then like what can we kind of give them? So, and I would encourage other researchers to sort of think in the same way. The other really good experience we've had is our close partnerships with our clinicians. And we just ask them, like, how are you handling this? Because clinicians have to be very creative all the time. And there's a lot of trial and error that happens. And they will tell you, like, yeah, we tried what you told us and it doesn't work. But what we did do is we modified it this way. And we're seeing good results, but we don't have data to back it up. And then we take that back into the lab and then we study it and validate it. And maybe we refine it a little bit. But having a good partnership with your clinicians and having a good two-way conversation is really invaluable.
Yeah, and we have just about 5 minutes left here. And I just want to ask you, you've had your hands in so many just pinnacle research papers and just moving the needle forward for concussion research in the last couple decades. What excites you? What keeps you going? At the end of the day, I can only imagine the administrative paperwork that you have to do and deal with from day to day as dean. And I know that burns people out, but really, why are you still here? Why are you still doing this? Why do you keep showing up for this population of patients?
Well, first of all, thanks. I appreciate the kind words. I think there's a couple things. I think the first is I have always really enjoyed taking a very complex question. Doesn't make a difference what it is, but take a super complex question and then break it down into manageable chunks and then kind of chipping away at those things. And concussion is just that, right? I mean, I think, we talked about kind of my pathway and kind of, at first it was sort of evaluating sideline clinical tools and biomechanics and now kind of looking at the long-term effects. But if you look across all those, it's not like I did one paper on sideline care or sideline evaluation. There's a series of them in there. So you're just asking like small, manageable chunks of information and chipping away at those. Really, kind of what the excitement is, it's that fresh data set. There is nothing better. You're done with data collection, and then you're like, okay, the data's clean. I'm ready to analyze, and just sort of like, what is it going to tell me? Like, I'm excited to run that first t-test or a NOVA or a multivariate, and what am I going to see? I've always been a slave to what the data drives the next step. I try to go in as agnostic as I can to the results. And no matter what they say, I'm like, well, the data are what the data are. This is how we interpret it. And then let's ask the next question. I think kind of in parallel to that, really what I have a lot of fun with are the students. And, I have had super fortunate luck over the years to have a series of just phenomenal doc students, trainees that I've been able to work with, and watching them kind of grow, shape their research agenda, shape their identity around concussion, and then as they leave and go on and do other things, it's just sort of like a magical experience. It's a little bit like being a parent, just time and time again. And so it's just fun to watch that happen. So I think it's sort of those combination of things of like knowing that you're sort of contributing to a bigger, more complex problem, and then helping other people kind of do the thing.
Yeah, at the end of the day, our mantra is teach one, serve many. And you're obviously doing that, at a university and then international guideline level. We're doing it smaller at the academy level side of things. But again, we had some folks come through our alpha program for part 2 and has 60 hours of content with us and 60 plus. And 2 of those students came through, and one of our special ops guys was like, hey, Jess, did you realize that those students don't treat concussion? They're just here to learn from you and just kind of implement that into their practice. And it's so, I think if you're a new grad, if you're 40 years out, if you're feeling a little bit burnt out in clinical care, concussion is just such a wonderful space to like entree into, because again, it really touches all things from physiologic to sports to just return to life and function. And it touches all the things. So I also feel as invigorated with the topic as well. And I just am super grateful to be able to translate this information that you guys are putting out between Brian Hainline and Mike McRae, yourself, and the entire Care Consortium folks to really just put this out for next day knowledge translation. So I hope this reaches the people that it needs to get to. I hope it motivates the young researchers that are listening to us as well. We know that they're there and they tune in. And again, I've got my little, my trusty CISG book still on my desk. I have to say thank you for that swag, and I keep it in mind. Let's talk about that. So where can folks sign up to become members, and what's the value of membership, especially in this climate that we're in, at least in the United States, but this is an international membership, where again, unfortunately, the CDC, the brain injury section, the TBI section was just eliminated by this administration. And we just want to make sure that we're showing up to make sure that we can support, people who are doing really good work for the patients that need it. So, take it away as we wrap up.
Yeah, so thanks. Appreciate the option to talk about CISG here a little bit. So if people are interested in the group, they can go to concussioninsportgroup.com. If they want to become a member, they can click, I think it's on the top right-hand side, there's a Join CISG button there. We have a couple different tiers of membership, whether you're have a terminal degree or practicing in some other categories there. So just pick the one that's appropriate to you. Once you become a member, access to all of our tools. I think the SCAT's been translated to 11 or 12 different languages. We talked about the SCAT wheelchair that's coming. So people have access to all of that. There's some other educational resources that are on the website, but sort of have to log in to get to them, so that the members can get to that. And then I can't make any promises here, but we're also having some conversations about early registration for the big consensus meeting. Obviously, the symposium that happened in Milwaukee earlier this year, we want to redo that. So it would give the members access to that to register and come and learn. And then I think you touched on this a bit. We are an international organization. So I would really, this is not US centric. I know we're based here, but I'm really, as president, trying to push for to broaden our membership and have a good international representation. So definitely would encourage your audience that's around the world to log in to the website and take a look and consider joining us.
Yeah, fantastic. And I think really at the end of the day, the camaraderie of such a small group, people show up same conference after conference after conference, and you just get to know people, whether you want to or not sometimes, Steve, so respect. But at the end of the day, the camaraderie of being together and having the conversations and kind of leaning into the mission, the same mission, is really just fantastic. So again, thank you for the work that you're doing. Thank you for showing up for this population. Thank you for doing it with integrity and doing that transition for us. And, at the end of the day, keep shining bright. Yourself, Dr. McRae, Dr. Hainline, and that whole entire crew that you guys are lifting up. for Care Consortium. We just thank you for all the work that you do.
Thanks, Jess. I appreciate the kind words and the opportunity to talk about it today.
Take care. This conversation highlights exactly why we need science with integrity, research with heart, and clinical care that reflects the real lives of the people that we serve. Whether you're a provider working in the front lines of concussion care or a student just entering the field, I hope that you can find the passion in data sets that Dr. Broglio has that I have with the same passion when I find a fresh set of pavement when I go biking on the trails. If you want to get involved or stay informed, I encourage you to explore and join the Concussion in Sport Group at the concussioninsportgroup.com, a global organization committed to research, clinical tools, and consensus built on transparency and collaboration. And as always, if this episode resonated with you, please share it, leave a review, and subscribe to the podcast on your favorite platform. You can also explore our programs and community resources at concussioncorner.org. Thanks for being a part of our Teach One, Serve Many community, and take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.